think about holding a newborn, so tiny, seemingly fragile, yet their little lungs kick in immediately, or, well, we hope they do. Today, we're doing a deep dive into something that affects those crucial first breaths, infant respiratory distress syndrome, IRDS.
That's right. And we're using some focused revision notes today, really aiming to pull out the absolute essentials you need on IRDS. Think of it as your fast track to getting a solid handle on it.
Okay. You sometimes hear it called hyaline membrane disease too, right?
Yes, exactly. Though IRDS is more common now.
Mm-hmm.
But essentially, it's all about the baby's lungs just not making enough of this substance. Surfactant.
Surfactant. Okay, let's unpack that a bit. It's this vital stuff made in the lungs, usually starts ramping up production after about 30 weeks gestation.
Yeah, around then. And its main job is to lower what we call surface tension inside the alveoli, those tiny little air sacs in the lungs.
Like how soap helps water spread out instead of beating up.
That's a great analogy, actually. Yeah, it reduces that tension.
And why is that so important?
Well, that reduced surface tension is key. It stops those really delicate alveoli from collapsing completely every single time the baby breathes out.
Ah, so it keeps them slightly open, ready for the next breath in.
Precisely. Makes the whole process much less effortful.
But in IRDS, there isn't enough surfactant. So what's the consequence?
Right. So without enough of it, the alveoli tend to collapse on expiration. Just deflate.
Which must make it incredibly hard work to inflate them again with the next breath.
Exactly. It leads to this increased effort of breathing. You see them really working hard.
And there's more to it. Something about edema.
Yes, you get interstitial edema, tooth fluid building up in the lung tissue itself. And that, combined with the collapsing alveoli, makes the lungs stiff, less compliant. They just don't expand easily.
So the bottom line is, difficult breathing leads to problems with gas exchange.
Absolutely. You end up with low oxygen levels in the blood hypoxia and a buildup of carbon dioxide hypercapnia.
And in severe cases.
In severe situations, the body might even start diverting blood away from the lungs. It's called right-to-left shunting. Basically, deoxygenated blood bypasses the lungs and goes straight back into circulation, which obviously makes the hypoxia even worse.
Wow. Okay, so our mission here is clear. Get right into these notes, pull out the key facts on IRDS for understanding, for revision. Let's start with the why. What actually causes IRDS?
Okay, the number one cause, by far, really, is premature birth.
Being born too early.
Exactly. Babies born before their lungs are fully mature, especially before that 32-week mark, often just haven't had enough time to produce sufficient surfactant. It's fundamentally about lung immaturity tied to gestational age.
Makes sense. Less time cooking means less development. Are there other things that contribute?
Yeah, there can be. Sometimes there are genetic factors involved. These might affect how surfactant itself is produced or maybe the overall way the lungs develop structurally.
Okay, genetics. What else?
And then maternal factors can play a role. Things like infections during the pregnancy or maternal diabetes, even certain medications sometimes. These often work by increasing the risk of having a premature birth in the first place.
So they indirectly raise the IRDS risk by leading to prematurity.
Correct.
Okay, got it. Prematurity, immature lungs, genetics, maternal factors. Is there a memory aid for those main causes for revision?
There's a little one. Might help it stick. Think, Preemie Lungs Get Mad at Mom.
Okay, I like that. Preemie Lungs Get Mad at Mom. P, premature, L, lungs, immature, G, genetic, M, maternal. Nice.
Hopefully memorable.
Definitely. So we know the main group is preemies. But drilling down further, who's specifically more likely to get IRDS? What are the risk factors?
Right. Well, as we said, premature delivery is the big one. Can't emphasize that enough.
Okay, beyond that.
Male infants seem to be at a slightly higher risk than female infants.
Interesting. Why is that?
The exact reasons aren't fully clear. Might be hormonal influences on lung maturation. Another one is delivery by cesarean section, but specifically C-section, without the mother having gone into labor beforehand.
Right, I've heard that. Why does labor help?
It's thought that the stress of labor, the hormonal surges, actually gives the baby's lungs a bit of a kickstart, helps mature them, maybe clear fluid a bit better, stimulates surfactant. So if you bypass labor with an elective C-section...
You miss that natural trigger.
Okay.
What else?
Other factors include hypothermia, letting the baby get cold after birth, perinatal asphyxia, which is a lack of oxygen around the birth time, maternal diabetes, as we mentioned under causes, is also a direct risk factor itself, and a family history, if siblings had IRDS.
Okay, A few key things there. The notes also mention secondary surfactant deficiency. What's that about?
Ah, yes. Secondary deficiency is a bit different. This is where a baby might have had enough surfactant to start with, or, nearly enough, but then something else happens that damages the lungs or interferes with the surfactant.
Like what kind of things?
Well, things like intrapartum asphyxia, again, pulmonary infections, pneumonia is a big one, or bleeding into the lungs, meconium aspiration, where the baby breathes in meconium stool.
Oh, right. That can cause damage.
Yes, it's quite inflammatory. And even sometimes the treatments we use, high levels of oxygen, or the pressure from ventilators, while life-saving, can sometimes cause lung injury, what we call oxygen toxicity or barotrauma, and that can impair surfactant function too.
A potential side effect of necessary treatment.
Unfortunately, yes. And finally, certain congenital conditions where the lungs haven't formed properly from the start, like a congenital diaphragmatic hernia or pulmonary hypoplasia, naturally mean there isn't enough functioning lung tissue or surfactant.
Got it. So that's a whole other set of circumstances leading to surfactant problems. Okay, we've covered the why and the who. Now let's get into the mechanics, the pathophysiology. What's actually going wrong inside those tiny lungs?
Okay, so at its core, like we said, it's the lack of surfactant leading to the alveoli collapsing atelectasis. But it's not just that they collapse once. It triggers this really damaging cycle.
A vicious cycle.
Exactly. The collapse makes it harder to breathe, so the baby increases their respiratory effort, they work harder. But this increased effort, paradoxically, can cause more lung injury and inflammation.
Oh, wow.
And then the poor oxygenation and the CO2 build up the hypoxia and hypercapnia. They lead to acidosis.
Yeah.
The blood becomes too acidic.
And that's bad for...
Well, acidosis itself is dangerous.
Yeah.
But it also further messes up the function of whatever little surfactant is there. It makes the existing surfactant work even less well.
So the problem feeds back on itself, making everything worse.
Precisely. It's this downward spiral. Collapse leads to effort, leads to hypoxia-acidosis, which leads to more surfactant dysfunction, which leads to more collapse.
And the overall effect on getting oxygen in and CO2 out.
Severely compromised. Gas exchange just plummets because those collapsed alveoli aren't taking part. And that's when you can get that right-to-left shunting we talked about, where blood just bypasses the lungs altogether, deepening the hypoxia. Understanding that cascade really highlights why jumping in early with treatment is so vital.
It really does paint a stark picture. Okay, so if a newborn is struggling to breathe, how do you know if it's IRDS or maybe something else presenting similarly? What are the differentials?
Yeah, crucial question. Because the treatment can differ quite a bit. Several things can look like IRDS initially. First off, pulmonary air leaks. Things like pneumothorax air leaking out of the lung into the chest space, or interstitial emphysema, where air gets trapped in the lung tissue itself.
Okay, air leaks. What else?
Infections are a big one. Pneumonia, or generalized sepsis, can absolutely cause respiratory distress. You always need to rule those out.
Makes sense.
Then there's aspiration. Maybe the baby inhaled amniotic fluid, or meconium. Transient tachypnea of the newborn, TTN, is another common one.
PTN, that's usually milder, isn't it? More about fluid clearance.
Generally, yes.
Yeah.
It's usually caused by delayed clearance of fetal lung fluid, tends to resolve quicker than IRDS, often within, say, 24 to 72 hours. But early on, it can look similar.
Okay. Any others?
Definitely.
Yeah.
You have to consider congenital problems, underlying lung anomalies, or heart defects, primary persistent pulmonary hypertension, PPHN, where the baby's circulation doesn't switch over properly after birth, and even some metabolic or hematological issues can sometimes present with breathing difficulty.
Wow, that's quite a list to work through. Is there a mnemonic for remembering those differentials, like the one for causes?
There is one that floats around, paint see me.
Paint see me. Okay, break that down.
P is for pulmonary air leaks, I for infection, A for aspiration, T for TTN, C is for cardiac or congenital lung problems, M is for metabolic or hematological issues.
Paint see me. Pulmonary air, infection, aspiration, TTN, cardiac congenital, metabolic aim. Got it. That's handy.
And the me can also remind you there might be miscellaneous or other things too.
Good point. Okay, moving on to the numbers. What's the epidemiology? How common is IRDS, especially thinking about the UK context mentioned in the notes?
Well, the key thing, epidemiologically, is that incidence and severity are really strongly linked inversely to gestational age.
So the earlier the baby, the higher the risk, and the worse it's likely to be.
Exactly. But the really good news is that the overall incidence has dropped quite significantly over the years. And the main reason for that is the widespread use of antenatal corticosteroids. giving steroids to moms at risk of premature delivery has made a huge difference.
That's fantastic.
Yeah. Interestingly, the notes also mention that things like maternal hypertension or prolonged rupture of membranes have been associated with a lower incidence. The mechanisms aren't totally clear, maybe some stress adaptation in the fetus, but is an observed association.
Fascinating. Okay, now, the clinical picture. What does IRDS actually look like when you see it in a newborn?
Right, so it's almost exclusively seen in preterm infants. And the signs of respiratory distress usually start pretty soon after birth, often within the first few hours, sometimes immediately.
And what are those classic signs?
Key things to look for: cachypnoea, breathing really fast, persistently; expiratory grunting, this characteristic noise they make as they breathe out, trying to keep the airways open.
Like a little grunge with each breath.
Exactly. Then you see retractions, the skin pulling in under the rib cage, the subcostal area, and between the ribs, intercostal retractions. Shows they're using extra muscles to breathe.
You can really see the effort.
You can. And if you listen to the chest with a stethoscope, the breath sounds might be quite diminished, quiet. Cyanosis is another sign, that bluish tinge to the skin, lips, nail beds showing low oxygen levels. And finally, nasal flaring, the nostrils widening with each breath in. Again, a sign of working hard to get air in.
Okay, so a whole cluster of signs pointing to significant breathing difficulty. Do the symptoms change over time?
Yes. Typically, they tend to worsen over the first, say, 48 to 72 hours. The baby might get more tired, more fatigued from all that effort. They can start having periods of apnea pauses in breathing.
Pauses longer then.
Usually defined as more than 20 seconds, or shorter, if associated with a drop in heart rate or oxygen saturation. And their oxygen levels, the hypoxia, will likely get worse without intervention.
Right. Is there a quick way to remember those initial signs? Another mnemonic, maybe?
Yep, there's one for the signs too. TERD-CN.
TERD-CN.
Q for tachypnoea, E for expiratory grunting, R for retractions, D for diminished breath sounds, C for cyanosis, and for nasal flaring.
TERD-CN, tachypnoea, expiratory grunting, retractions, diminished sounds, cyanosis, nasal flaring. Perfect.
So once you see those signs, what investigations do you do to confirm it's IRDS and see how bad it is?
Blood gases are absolutely top of the list. Arterial or capillary blood gas, that tells you the oxygen level, PA2, the carbon dioxide level, PaRQ2, and the pH lets you see if there's respiratory acidosis or metabolic acidosis from poor oxygen delivery.
Critical information. Definitely. And continuous pulse oximetry, of course, to monitor oxygen saturation non-invasively. We generally aim for sats between 91 and 95% in these babies. Lower can be harmful, but too high can also cause problems like ROP later on.
Okay, 91, 95%. What about imaging?
Imaging is key. Traditionally, a chest X-ray. It shows characteristic findings in IRDS, often described as a ground glass appearance, low lung volumes, air bronchograms.
Ground glass.
Yeah, like a diffuse haziness across the lungs.
Oh.
Increasingly, though, lung ultrasound is being used right at the bedside. It's very sensitive for IRDS changes, like confluent B lines, pleural line abnormalities. Some argue it's better, faster, avoids radiation.
Interesting. Ultrasound gaining ground. Does X-ray still have a role?
Oh, yes. X-ray is still often done, and it can sometimes be better for spotting those air leak complications, like a pneumothorax. So often they complement each other.
Okay. What other tests are standard?
You definitely do baseline blood tests. A full blood count looking for infection, checking the hematocrit for anemia. Electrolytes, glucose preemies are prone to low blood sugar. Kidney and liver function tests.
Checking overall stability.
Exactly. And an echocardiogram, an ultrasound of the heart, is really important too.
Why the echo?
Several reasons. To look for a patent ductus arteriosus, the PDA, which is common in preemies and can worsen respiratory issues. To check the direction and degree of any shunting. To estimate pulmonary artery pressures, looking for pulmonary hypertension. And, crucially, to rule out any underlying congenital heart disease that might be causing the symptoms.
Right. Ticking off one of the major differentials.
Precisely. And finally, cultures. Blood culture is standard, maybe CSF or urine if sepsis is suspected, to rule out or treat infection.
Okay, a really thorough workup. Now, the crucial part, management. How do we treat IRDS?
The absolute cornerstone, the game changer in IRDS care is surfactant replacement therapy.
Giving the baby the surfactant they're missing.
Exactly. We administer synthetic or animal-derived surfactant directly into the baby's trachea, into the windpipe.
How is that decided? When to give it?
There's been debate, prophylactic versus selective. Prophylactic means giving it immediately at birth to very high-risk babies, say below a certain gestation. Selective means waiting until the baby shows signs of IRDS and has perhaps been stabilized initially on some respiratory support like CPAP. Current trends lean more towards early selective treatment after CPAP stabilization for many babies.
And the benefits are clear.
Oh, absolutely. Huge benefits. It significantly decreases the risk of pneumothorax, reduces interstitial emphysema, and most importantly, lowers mortality. It helps open up the lungs.
Are there downsides or risks?
There are potential risks, yes. It's been associated with a slightly increased risk of appendectis arteriosus, the PDA we mentioned, and less commonly, pulmonary hemorrhage, bleeding in the lungs has been reported, though the link is complex.
Okay, and are there different ways to give it?
Traditionally, it involves intubating the baby briefly, squirting the surfactant down the tube, and ventilating. But newer, gentler techniques are emerging, like MISA, minimally invasive surfactant administration.
MISA.
Yeah, using a very thin catheter passed through the vocal cords, often while the baby stays on CPAP. The idea is to avoid full intubation and ventilation if possible. It's becoming quite popular.
Interesting development. What about oxygen and breathing support?
Also vital. The goal is maintaining that target oxygen saturation, 91–95%. How we deliver it depends on severity.
Milder cases.
For mild IRDS, maybe just supplemental oxygen via head box or nasal cannula is enough. But most babies with significant IRDS need more. Continuous positive airway pressure, CPAP, is a mainstay.
CPAP helps keep the alveoli open.
Exactly. It provides continuous pressure to splint the airways and alveoli open, reducing that collapsing tendency. It can be delivered via nasal prongs or a mask. Sometimes continuous negative pressure, CNP, is used, but CPAP is much more common.
And if CPAP isn't enough,
then the baby would need intermittent positive pressure ventilation, IPPV, being put on a ventilator. This is often needed for the most severe cases, or if surfactant is being given via the traditional route. The aim is always to use the gentlest ventilation possible to minimize lung injury.
Okay, surfactant, oxygen, CPAP, ventilation. What about general supportive care? These babies are so fragile.
Absolutely critical. Gentle handling is key. Minimize disturbances. Temperature regulation is vital. Keeping them warm in an incubator or under a warmer prevents cold stress, which uses up energy and oxygen.
Right. What about fluids and nutrition?
Meticulous fluid management is needed. They often start on intravenous fluids, getting electrolytes and glucose that way. Nutritional support is crucial. IV nutrition, or TPN initially. Then, as soon as possible, we try to start tiny amounts of milk feeds via a feeding tube into the stomach trophic feeds.
And breast milk is preferred.
Oh, definitely. Breast milk is always the best option. Provides antibodies, growth factors, easier to digest. Donor milk is an alternative if mom's milk isn't available. We also closely monitor their circulation, blood pressure, check for anemia, and treat if needed. And antibiotics are usually given initially until infection is ruled out.
And supporting the parents through this must be huge.
Immense. It's an incredibly stressful, frightening time for families. Providing clear, honest communication, involving them in care decisions, offering emotional support, it's an absolutely essential part of neonatal intensive care.
Couldn't agree more. So with all this advanced care, what's the overall outlook? What's the prognosis for babies with IRDS now?
The prognosis has improved dramatically. Really, it's one of the big success stories of neonatal medicine. Thanks to antenatal steroids, surfactant therapy, gentler ventilation, outcomes are much, much better than they were, say, 30 or 40 years ago.
That's so good to hear. What are the survival rates like?
In developed countries with good NICU facilities, the mortality rate specifically from IRDS is generally less than 10%. Survival rates overall for premature infants needing this level of care can be up to 98%, especially for those born a bit later in gestation.
Wow, less than 10% mortality from IRDS itself.
Yeah, but it's important to remember, mortality rates were still significantly higher in low-income settings, where access to this technology and expertise is limited.
A stark reminder of health inequalities. Does birth weight make a difference?
Yes. Generally, babies born weighing over 1,500 grams, about 3.3 pounds, tend to have a significantly better prognosis than the extremely low birth weight infants. But even the tiniest babies have much better chances now. The key takeaway is just how much progress has transformed survival.
That's really encouraging, given how serious it can be. What about prevention? Can we stop IRDS before it starts?
Yes, prevention is key, and we have some very effective strategies. The most important one we've mentioned is antenatal corticosteroids.
Giving steroids to the mother.
Exactly. Giving medications like dexamethasone or betamethasone to mothers who are at risk of delivering prematurely, ideally at least 24–48 hours before birth. This dramatically accelerates fetal lung maturation and surfactant production. It reduces the risk of IRDS by around 40%. It's standard practice now.
Massive impact. What else?
Well, sometimes doctors might use tocolytic drugs medications to try and stop or slow down premature labor. The main aim of this isn't usually to stop the birth indefinitely, but often to buy that crucial 48 hours for the steroids to work effectively.
Delaying tactics for the steroids.
Precisely. Also, good control of maternal diabetes throughout pregnancy is important, as poorly controlled diabetes is a risk factor. And finally, preventing hypothermia in the newborn right after delivery, keeping the baby warm, is a simple but vital preventative step.
Okay, so several angles for prevention. Now, despite the improved survival, we know prematurity itself carries risks. What are the potential complications associated with IRDS, either acutely or later on?
Right, there are definitely potential complications. In the acute phase, some are related to the procedures themselves, like lines or intubation. The underlying lung disease makes them prone to alveolar rupture air leaks, like pneumothorax, pneumomediastinum, PIE, pulmonary interstitial emphysema.
The air leaks we mentioned as differentials.
Exactly. They can also be complications. Intracranial hemorrhage, bleeding in the brain, is a serious risk, especially in the most premature babies and those needing a lot of ventilation. The risk of PDA, patent ductus arteriosus, is higher. PPHN, persistent pulmonary hypertension, can occur. Pulmonary hemorrhage, though less common, is a risk. And these babies are more vulnerable to hospital-acquired infections, necrotizing enterocolitis or NEC, a severe gut problem, sometimes even spontaneous intestinal perforation, and they often have more issues with apnea of prematurity.
A challenging list in the short term. What about longer-term issues?
The main long-term respiratory complication is chronic lung disease, often called bronchopulmonary dysplasia, or BPD. This results from the initial lung injury and the effects of oxygen and ventilation.
So, lasting lung problems.
Yes, requiring oxygen or respiratory support for weeks or months, sometimes longer. Retinopathy of prematurity, ROP, is another major concern, abnormal blood vessel growth in the eye, which can affect vision, potentially severely.
Related to oxygen levels, often.
Yes, fluctuating oxygen levels and prematurity itself are key risk factors. Then there are neurological risks, an increased chance of cerebral palsy, developmental delays, learning difficulties later on, and potential hearing or visual impairments unrelated to ROP can also occur. It really stems from the overall vulnerability of all the organ systems in a very premature baby.
It really underscores that survival is the first step. Supporting long-term health and development is crucial too. Okay, so to wrap up our deep dive, IRDS fundamentally about surfactant deficiency in preterm infants. A serious condition, but one where outcomes have been transformed by advances like antenatal steroids and surfactant therapy.
Absolutely. Understanding the causes, the risks, how it presents, and the management principles, including supportive care, is just vital for anyone looking after newborns.
Definitely. And, considering those potential long-term complications we just discussed, it really makes you think. What are the most promising avenues for future research? Where can we make the next big leap in preventing IRDS or mitigating its long-term effects? Something for you, the listener, to ponder.
A great question to leave people with.
Well, that brings us to the end of this deep dive on infant respiratory distress syndrome. We really hope this focused chat has helped clarify things for your learning and revision.
Yes, hope it was useful. And remember, for more MSRA revision resources, do check out paththenmsra.com. And there's also freesra.com for free questions and materials too.
Excellent resources. Thanks so much for joining us today. Until next time.